thank you for joining us. I'm your host, Nada Youssef, and you're listening to Health Essentials Podcast by Cleveland Clinic. Today, we're broadcasting from Cleveland Clinic main campus here in Cleveland, Ohio, and we're here with Dr. Emad Estemalik. Dr. Estemalik is a headache specialist in the Center for Neurological Restoration and section head for headache and facial pain here at Cleveland Clinic. And today, we are talking about headaches. Thank you so much for coming in today.
Thanks for having me. Happy to be here.
Sure thing. And please remember, this is for informational purposes only, and it's not intended to replace your own physician advice. So before we jump into the topic, I'm going to ask you some questions off topic
Sure.
to get to know you better.
Yeah.
All right. So how many languages do you speak?
So I grew up in Egypt. So my first language is Arabic, of course, but born and raised for my first 6 years of life in Germany. So German was my second language. Of course, I was taught English at school, so that became my third language. By middle school, we took French at school, so that was my fourth language. And then when I came to the U.S. and met my wife, who is of Mexican heritage, so I learned Spanish. So by now, 5 languages.
Wow, proficient in all of them?
Well, I think my French is kind of, going into an area of the brain that I can't get anymore. Spanish, I'm getting much better, but still very efficient in both German and Arabic, and of course English.
That's amazing. Good for you. How about the best food you've ever had?
I got to go with Middle Eastern food since also some of the healthiest foods. So I would say shish taouk and tabbouleh would be my favorites.
Yeah. Yes. All right. And what about best concert you've ever been to?
That's a good question. Probably going back in time, growing up in Egypt, it was 2006, just a year before I moved to the US. Shakira was doing a Middle East tour, and she came to Egypt, and she held one of her conferences by the pyramids.
Wow.
And one of the most magnificent concerts I've ever
been at.
Up and lights everything. Everywhere. They lit the pyramids. For anyone who's ever been to the pyramids, really, they host a lot of concerts by the pyramids. Pink Floyd was actually just there. Wow. It's unbelievable. So Shakira by the pyramids, that's something I'll never forget.
That sounds amazing. Yeah. That sounds amazing. Thank you for that.
Yeah.
So let's go back into topic.
Sure.
So according to the International Headache Society, there are over 150 headache categories. Yeah. So for practical purposes, let's just talk about the most common primary ones during this podcast. But first I want to ask you, who suffers more frequently from migraine headaches?
Yeah.
Would it be man or woman?
So it is actually women, and we know the data, and if we go by prevalence, 20% of women roughly have migraines versus 6 to 8% of men. Wow. So definitely women tend to be more affected than men.
So why is that?
So basically it comes down to the hormonal factor, and it tends to be really the fluctuation of hormones that play a huge role in migraines. That's why women, mainly during childbearing age, anywhere from by the time they start their menstrual cycle till menopause, it is the time they have the vast majority of their migraines. Usually they do improve after menopause, because then you have a steady level of hormones. So it is the hormonal component.
You said 20% of
20%, yeah, 20% of women have migraines, less than 10%, somewhere between 6 and 8% of men. Wow. So definitely double the amount.
That's huge. Yeah.
Yeah.
So I would like to talk a little bit about the most common types of headaches, and what they're called, where they're located, how long they last, all kinds of stuff. So first of all, most common one is tension headache.
Absolutely.
So what is the tension headache?
So tension type headache definitely is the most common type. It is typically also a headache that we don't see often in clinic because, again, it's easily manageable and self-manageable. A lot of primary care physicians take care of headaches, but it is the usual headache that every one of us usually tends to experience. So it is, basically a pressure. It could last anywhere from half an hour to, a few hours. Not really severe. People can really go on with their lives. No nausea, no vomiting. Typically not much lighter sound sensitivity. So unlike migraines, it is not a debilitating headache, not severe enough. And really patients report, usually periods of, time where they have an increased frequency of these headaches when they are under stress, or there are other factors playing a role. But definitely tension type headaches tend to be the most common type of headache that patients experience.
So you said it's the most common, but then that's the least amount of patients that you see. Is that because over-the-counter medication
Exactly.
fixes
So
it?
over-the-counter usually work, and it is not severe enough, and it doesn't raise a concern to patients or anybody when they have that kind of headache to see a physician or any healthcare provider.
So it's mild. You'd say
Mild,
it's very mild.
usually
Okay.
mild to moderate, never hit severe.
All
Correct.
right. So second one, migraines.
Second one, migraines. And migraines tend to be the most common type of headache that we typically see in our headache clinic, or even that primary care physicians see. And as a matter of fact, headache tends to be one of the two most common pain complaints that any physician encounters.
Wow.
So together with back pain, these tend to be the two most common pain complaints that providers see. So migraines typically are more severe than tension-type headaches. They last anywhere from a few hours, but they can go a few days. So patients can sometimes go 2 to 3 days, typically one-sided, but can also occur on both sides. So patients usually don't think it is a migraine because it can occur on both sides, but that's not always the case. And then patients have these classic features. They'll get nauseous, they'll want to throw up. Sometimes they do, and then significant light and sound sensitivity, a throbbing sensation in the brain, and it is not, these kind of headaches usually do not just simply respond to over-the-counter meds.
So then it can mess with your quality of life, driving.
Absolutely,
things
absolutely,
like that.
yeah. So they do, and really what determines how much it affects someone's quality of life or social activities is both the frequency of these migraines, how many a patient can get in a month, and also the severity. So how bad it gets, and it can really put people down from doing things, stopping what they're doing, having to be in a dark, quiet room, try to sleep it out. So that is when this raises the concern for a migraine.
And then over-the-counter medication doesn't work on this. So what kind of treatments?
So typically over-the-counters don't completely abort such headaches. There are two ways really to manage migraines. There are medications that we use to abort these headaches, and patients that get migraines know about this. So one of the class of medications that we use are called the triptans. For instance, sumatriptan, rizatriptan. There are several drugs in that family. But then if patients also have a high frequency, that means they have 10, 15 headache days a month or more of migraines, then typically we discuss with the patient a daily migraine preventive. And we can talk about that in detail a little bit, what kind of preventive strategy we use to reduce the frequency, because some patients will say it's not just one migraine a month or 2 migraines a month I'm getting, it's 10 to 15, and that can really affect somebody's quality of life.
Sure. What about cluster headache?
So cluster headache, definitely far less common than migraine and tension type headache. Typically we see it more in men, so it doesn't affect women as much, and it is by far one of the most severe headache types in terms of the pain severity. So a patient will usually come, and the presentation is pretty classic. It's always one-sided around the eye, and patients will complain about like significant redness, droopy eye, nasal stuffiness, and really being agitated. Some patients actually use the term suicide headache for that. Wow. That is how really severe this headache can be. Now, the good news about cluster headache, it does not occur as frequent as migraine in terms of year long. So typically it comes in cycles, and patients will know, okay, I'm hitting my cluster cycle right now, so it can happen once a year, once every few years, can last a few weeks, and then we help the patients during that time to kind of reduce the duration of the cycle and really abort these attacks early on with some treatments.
Sure, and then you mentioned droopiness and color change.
Yep.
I mean, there's physical changes
Absolutely.
to your face.
Yeah, we call them actually autonomic symptoms, where a teary eye occurs.
Wow.
And a red eye, and again, some of these other symptoms, nasal stuffiness, runny nose, and patients know about. I mean, they'll always know this is different from any kind of headache I've had before. And again, the treatment is different than migraines, but also the underlying reason, or what we call pathogenesis for this headache, is different than migraine as well.
Right, and it's only one-sided.
Only one-sided. That's the classic thing about cluster headache. It is only one-sided. In fact, it hardly shifts side. So patients that have had cluster headaches for many years, and when they get it in cycles, they actually know it's usually the right side or the left side.
Wow.
Yeah,
wow.
yeah.
How about new daily?
So new daily persistent headache is, this is not a headache a lot of people are familiar with, and it is rare. We do see it, but the classic presentation with new daily persistent headache is that you can get a patient that may have never had a history of headaches before, and then out of the blue, they say, well, I woke up one day, or there was something that happened, for instance, like they had a viral illness or something, and then they're left with this constant ongoing headache that just doesn't subside. And something very classic a patient says is, I have some degree of daily 24-hour pain or discomfort in my head, and I get these spikes of pain where it gets worse, and then I'm left again with a 24-hour pain.
Wow.
And for some, it's very hard to comprehend how come out of the blue I just have a headache that doesn't go away.
Right.
We still don't understand the exact pathogenesis of this headache. Again, it's rare, so we're fortunate that it doesn't affect too many people.
Sure.
But it is one of these headache types that we always take very seriously in terms of our workup and what kind of tests we need to run to rule out any secondary causes of headache. So another reason for, when patients describe, I'm having the worst headache of my life, could be actually a ruptured aneurysm. And this is something that would require immediate attention, because often, the quicker you can get in with a provider, and that's usually a case where you got to go to the emergency room, is the quicker we can get a surgical intervention to fix this aneurysm. Typically, a ruptured aneurysm can present with, a severe headache, and it can present with some other neurologic signs as well. So, a droopy eyelid, sudden weakness in one side of the body, again, facial droop. So again, this is a major concern we often have when we hear, the worst headache of my life, or what we also describe as a thunderclap headache.
Sounds good. And we'll get a little bit more into treatments,
Yes.
but I want to kind of talk about preventable measures for headaches in general.
Yeah. So if you talk about preventable measures, so there's, and let's talk about migraines for a minute, because that tends to be the one headache disorder that usually takes the bulk of the preventive strategy. So first, you have, of course, your typical daily preventives when a patient says, I have more than 15, 20 headache days a month. And this can vary. We use different kind of medication. So daily medication can vary from seizure meds to blood pressure meds to antidepressants. These are three classic families of drugs that we use to reduce headache or migraine frequency. Then we get into the procedural aspect. And for a few years now, the FDA has approved onabotulinum toxin or Botox injections for prevention of migraines as well. So this is typically a procedure that's done every 90 days. And we usually go to this option when patients have failed or tried already a few of the oral preventives. Then as of last year, we have three drugs on the market that are injectable drugs. So this is the newest sort of class or family of drugs that are used now for migraine preventions. They're called the monoclonal antibodies. And these are either monthly or quarterly injections that a patient can administer themselves at home. And it's basically a very simple injection. And it acts on a receptor that we've studied for many years now. It's called the CGRP receptor. And it acts on that receptors in terms of reducing headache or migraine frequency. They've been on the market now a lot. It's been a sort of life changer for a lot of patients, and we've seen great results with some of these drugs.
So with these treatments, it depends on the frequency.
Absolutely,
It depends on just how.
Any preventive strategy always depends on the frequency.
Okay.
You never want to expose any patient to a procedure or a daily medication if they don't need to, and this is always the first discussion we have. There are really guidelines of when we bring up, the need for a daily medication. It's just like any other disorder.
Right.
You take diabetes. When do you want to start a daily drug? Is when your blood sugars are high that you need to kind of do something about it. Same with high blood pressure. When migraines or headaches affect somebody's quality of life, and a patient says, half the months or more, I'm having a headache, simple abortive medication or over-the-counter medication don't do it.
Sure.
So that is one type of prevention that we do. The other type of prevention is also what kind of lifestyle modification a patient can do.
Right.
So this is where we usually have a good lengthy discussion about it. So one, of course, is always diet modifications. So we know there are certain food components or diet components that a patient can follow to reduce headache frequency.
Let's talk about that.
Absolutely. So diet is the big thing with migraine diet are usually two things, monosodium glutamate and nitric oxide. So we always tell patients to stay away from these two components and to watch out for food which has these two. So typical food like that is Chinese food, for instance, aged cheeses, red wine, ramen noodles, for instance, chocolate. So the list goes on. But the first thing I always tell a patient is you do not have to stop everything.
Right.
So it is basically in moderation. And patients are smart. They know, they often come and say, well, when I eat this, I get a migraine. And it kind of makes sense that there's certain triggers in a certain food type that can trigger these headaches.
Sure.
So really, we look at the list, we look at, what a patient likes to consume or eat, and then we take it from there. Caffeine is is also a big factor. Too much caffeine is actually bad for people with headaches, or especially people who have migraines.
How about too little caffeine?
So actually a good amount, which is usually anywhere between 100 to 150 milligram a day, which would equal, a tall Starbucks, not a venti, that can actually be protective. Okay. So patients will say, when I have my morning coffee, and we hear that from a lot of people, is that can actually help their migraines. So really the right amount of caffeine can also be of benefit to patients.
And for those that don't know what the tall, because it is confusing, that's a small cup of coffee.
That's a small cup of coffee. Okay. Once you go into the really large one, you're talking 400 to 500 milligram.
Wow.
And that in itself is a lot amount.
Yeah.
So
imagine all the sugar that you're adding.
Absolutely. No, absolutely not. Then any caffeinated drinks, processed food, we try to tell patients to stay away from as well.
Sure.
So really it is a good discussion we have, and a lot of patients do really well with this kind of lifestyle modification. And I like always to give patients a choice. We can first try what I call a conservative approach or conservative sort of strategy. And then if that does it, then great. The less medication, the better.
Exactly.
But still there's some patients, and we know approximately 2%, 2 to 4% of patients with migraines will go into what's called chronic migraine. Hence a preventive medication is needed.
Sure.
But you always want to take it one step at a time, especially with young patients where you're trying to avoid daily medication, or even older patients who may already be on a lot of meds and you don't necessarily want to add more.
Sure. And then how about dehydration? Sometimes I don't get a lot of headaches, but when I do get those tension headaches, I find that water will literally fix the situation.
So two things. So the right amount of hydration is crucial in terms of being protective against migraines or headaches, and then also not skipping meals. So really, having your breakfast, lunch, and dinner, and really at right intervals, right amount, is also of great benefit. So again, definitely hydration and the kind of diet regimen they follow.
Now, I read somewhere that increasing magnesium intake would help.
So typically, magnesium oxide is one of the over-the-counter medications that we add in terms of reducing migraine frequency. And there are really 3 over-the-counters that, based on our studies, we know can help. Magnesium is one of them, anywhere at 400 to 500 milligram. Vitamin B2 can also be very protective and can reduce migraine frequency as well. And then a third one is coenzyme Q10.
Yeah.
So coenzyme Q10.
Where do I get that?
So you can also get it over the counter.
Supplements?
Yeah, it's one of those supplements. It's great for the heart. So our friends in cardiology love that.
Okay.
So again, over the counter, just like Mag and B2. So these 3 usually can really help. And often patients prefer just to stay on over the counter supplements to reduce their headache frequency, and that often works.
And then one important thing we didn't talk about is sleep.
Yes.
Sleep, and then I would think stress and sleep really go hand in hand.
So sleep is one incredibly important element when it comes to headaches. And typically, if there's an underlying, and I like to call it undiagnosed or unrecognized sleep disorder, it can have a tremendous effect on the amount of headaches or the frequency of headaches patients get.
Sure.
So really taking a good sleep history, and we do that. We even have some questions that patients ask before they see us that kind of give us an idea if there is an underlying sleep disorder or not. Sure. And typically you hear patients may say, I wake up with a headache, or I wake up and when you hear I wake up during the night several times, this can already trigger the concern that there may be an underlying sleep disorder. And then really addressing this issue as well can have also great benefit in terms of reducing headache frequency. Right. So often these patients, will have to undergo a sleep study, and then we kind of get a better idea if there's a sleep condition or not.
Tend to be more stressful when you have less sleep, and it's a vicious
Absolutely.
cycle.
So stress is one major element that we kind of struggle with a lot, because again, everybody's life is unique and different, and stress can vary from work to family to personal issues. So again, it's and this is where really sort of self-awareness, really plays an important role. What can I do personally to kind of reduce my stress level?
Sure.
Again, we're all very busy, and we're often consumed in our daily activities.
Right.
But yes, this is one discussion we often have,
Sure.
about stress. Another important element is, and this is something we always joke about, that's something we can control, and that is the barometric pressure. So, and especially like you look at our weather in the past, few weeks, it is not uncommon that we go from 70, 80 degrees suddenly to 40 or 50 degrees. So it's not really the just hot or cold weather, but it's that sudden
itself.
Pressure change.
Sure.
So that
It's true. When it
absolutely.
rains, it can
cause
us to get
rain
headaches.
can cause that. Yeah, I hear that from a lot of patients.
Yes.
So rain, but then again, really the drop in temperature or the sudden rise in temperatures plays an incredible role in terms of.
And in Cleveland, we have tons of.
Yes. So like simply today, we're about to reach 75, 76, and we were just less than 50, 48 hours ago. So really, that sudden change does affect people. Affect people. Yeah.
Okay, I want to go back to the cluster headaches. I heard that cluster headaches are more common in smokers.
That is true.
Okay, let's talk a little bit about that. I mean, you think smoking would affect all of it, but why cluster?
So we don't understand exactly why smoking tends to predispose people with cluster headaches to having the disorder. But if you look at some data that we're familiar with, roughly 80% of patients with cluster do smoke. And there is a genetic sort of predisposition to cluster headache. And there are some studies that show that, staying away or stopping smoking actually can reduce the frequency of the cluster cycles that a patient experiences. So smoking is one big component.
Sure.
The other component for cluster headache is also alcohol. So typically patients with cluster headaches know that the minute they consume any alcoholic beverage, it can trigger a cluster cycle.
Wow.
So many of my cluster patients, I'm always very strict about, at least during a cluster cycle, you want to completely stay away from alcohol.
Sure.
Absolutely, zero amount of alcohol.
Right.
So that these two factors are definitely a big
Smoking and
player.
alcohol.
Yeah.
All right.
Yeah.
So how about if I'm getting a really bad headache?
Yeah.
Sometimes, we think it's like a life-threatening disease, a tumor. How do you know when it's just a headache, a bad headache that's coming and going, or it's something life-threatening?
So this is one of the most common questions actually that we get. Typically, if anybody experiences what they call the worst headache of their life, that always raises concern. Okay. So if somebody has no history of headaches and suddenly gets the worst headache of their life, whether they have associated or other neurologic symptoms, with it or not, this should be investigated right away.
Even if it's not consistent.
Even if it's not so if it is consistent, it's different. But if it's out of the blue, and somebody says, well, this feels different. I'm not familiar with headaches. I don't get them that often, and then they have the worst headache of their life. This requires the workup right away.
Wow.
If you look at a lot of data, typically headache alone, and this is something we always assure patients with, headache alone is not the sign of a brain tumor, unless it is manifests with other symptoms, that could raise the concern, or if it takes different features. And let me go through that. So typically, brain tumors present mainly with things like seizures, cognitive changes, sudden numbness, sudden weakness in one side of their body, vision changes, and then headache can be a hallmark as well. But headache alone wouldn't be the factor that raises concern. Yeah. Now, when would it be?
Right.
If the headache takes features like it's mostly present in the morning, with significant nausea or vomiting. So something that would raise the concern for what we call increased intracranial pressure. If a patient says, this headache is new, it worsens when I cough mainly or when I lay down, that also raises the concern. If a headache is locked primarily on one side with vision changes, that can raise a concern. But typically, again, your regular headaches here and there shouldn't raise the concern of a brain tumor.
This is very good to know, and hopefully nobody ever has to go through that.
Absolutely.
So I read about, I believe a rare type of headache is that thunderclap headache.
Yeah.
So what is that?
So thunderclap headache, it is a headache that we take very seriously. So the best way to describe it is a sudden explosion, or sudden excruciating pain that occurs in the head anywhere from a few seconds to a few minutes. And it is so severe that, it can bring somebody to tears.
Okay.
Such headaches to us always require every kind of workup that is needed to kind of rule out any secondary cause. So it goes from labs to the appropriate brain imaging to look, at the brain in general, at the brain vessels, because there are secondary causes that can cause, a thunderclap headache. A condition like RCVS, for instance, reversible cerebrovascular constriction syndrome, something like, a subarachnoid hemorrhage, something like a pituitary apoplexy. So there are a lot of secondary causes that can give you a thunderclap headache. So this is one of the headache disorders that always require immediate workup as well.
Okay. Yeah. So that is the worst headache of your life.
Yeah. So thunderclap headache you're absolutely right. That would fall in the category of, I just had the worst headache of my life.
Sure.
Yeah.
So I read a lot of information about headaches in preparation for this.
Yeah.
So I read a cell phone headache.
Yeah.
Is that a thing?
So
I mean, it sounds like it would be.
So
sure.
Yeah. So again, there's a lot of literature that talks now about like cell phones and smartphones being a reason for headache, but the data is not really consistent yet. Now we know that with frequent cell phone use or smartphone use, you are really exposed to a lot of electromagnetic waves. So there are some hypotheses that it can affect the blood-brain barrier, for instance, that it can alter the brain chemicals. But to really determine accurately, the effect of phones or, sitting in front of a screen, you got to look deeper in terms of, okay, what are the other circumstances? Am I just on the phone because, I'm running some errands, or I'm, talking to someone, or I'm under significant stress being on the phone? So there are many elements here. Again, we're all exposed to electromagnetic waves wherever we are.
Yeah.
So now, of course, putting, a smartphone or a phone, on your ear, a lot of times can have an effect. But again, we don't have yet enough information to really make that determination.
Okay, and speaking of electronics, sometimes when I binge watch my shows in front of TV, I find myself getting a headache and nauseous watching TV for too long.
Yeah. So,
what is that?
Yeah. So again, the best way to kind of actually, talk about this would be really to think about how do we react when we're sitting in front of a TV? So we're really tensed, we're really focused. So there's a lot of eye straining. There is a lot of sometimes eating. There's some sort of inner physiologic changes. When we're excited about watching a show.
We need to look at other factors.
But what's interesting is if somebody is predisposed to migraines or headaches, then again, it could be absolutely an important element when you watch too much TV. Right. Migraineurs, I mean, a big trigger for them is noise and sound. Noise and light. So that can be a factor. So if somebody's predisposed to migraines and they're sitting in front of a screen with bright lights and loud sounds, it could trigger their migraines as well. Sure. So if you're predisposed to having migraines or frequent headaches, then yes, sitting in front of a TV for a long time can induce the headaches.
Sure.
Yeah.
Okay. All right. Well, I know we talked a little bit about treatments.
Yeah.
Now I read somewhere as well that the most opioid users are headache sufferers.
Yes.
So I want to talk about that, and then if there's any natural remedy or coping mechanism that you can talk about that don't include drugs.
Yeah. So I'm glad you brought up, the question about opiates when it comes to headaches, because I want to be very clear about that. There is no role for any kind of opiate to treat any headache disorder. So opiates are not recommended for headaches in general. Okay. In fact, some of the studies we know, and they're very clear, really demonstrate that, if migraineurs use any amount of opiates, they are at risk of developing what we call rebound headaches or medication overuse headaches. Wow. So opiates can actually worsen migraines and headaches and yes, make it worse. Right. Now, what about sort of, natural ways to cope with that? There are many, and a lot of patients do really well with this. Mindfulness is big, and really patients do really well understanding, their body responses, relaxation techniques, biofeedback, yoga, phenomenal. So again, a lot of these, remedies can reduce the stress level, reduce somebody's pain, and reduce headache frequency as well.
So when you say mindfulness, just to be clear, it's meditation, kind of just sitting down, maybe like going hiking and forest therapy, all that good stuff. Yeah.
But again, back to opiates, especially that we face, an incredible crisis with the opiate use in America right now. Like I can tell you, in our center, we rarely use opiates for any headache disorder unless really there are other medical conditions where you really limit it in terms of what you can give patients. But there is no role for opiates when it comes to managing headaches.
That's very informative. Thank
Yeah.
you. Thank you so
Thank
much.
you. Thank you.
Well, we are out of time, but if
Yeah.
there's anything else that you want to talk about or tell our viewers.
No, again, thanks for having me, first of all. One thing I would want to add for a lot of patients that do experience headache is really to pay attention to how much over-the-counter painkillers they use as well. So simple, since we just talked about rebound and medication overuse headache, if somebody has a history of migraines or they're predisposed to having migraines, they can have actually more headaches if they use too much over-the-counter painkillers. And patients often don't know that. So I'll hear from patients that they've been taking, Excedrin migraine or any over-the-counter medication, 3-4 times a week. And then they say, well, then over time, I started having more headaches. And there is a reason for that. So even just consuming too much over-the-counter painkillers can have an effect as well in increasing somebody's headache frequency.
So what is too much?
Too much, usually our rule is no more than twice a week.
No more than twice a week. Very good.
And that's where the preventive strategy, we discussed the preventive strategy when patients say, well, I'm having, 3-4 headache days a week. And that's when we try to find the appropriate preventive strategy to reduce the frequency and to allow patients not to take too much over-the-counter painkillers.
Sure. Thank you. Thank you so much,
Thanks
Dr.
for having
Estemalik,
me.
for joining
Thank
us
you.
today. And thanks again to all of our listeners and viewers who joined us today. We hope you enjoyed this podcast. For an appointment with a headache specialist or for more information, you can call 216-636-5860 or toll free 866-588-2264. Or you can visit us online at clevelandclinic.org/headache. And to listen to more of our Health Essentials podcast from our Cleveland Clinic experts, make sure you go to clevelandclinic.org/HE podcast, or you can subscribe on iTunes. And for more health tips, news, and information from Cleveland Clinic, make sure you follow us on Facebook, Twitter, Instagram, and Snapchat at Cleveland Clinic, just one word. Thank you. See you again next time.